everyone. I'm Dr. P.C. Gupta, Chief of Vascular Surgery, Interventional Radiology and Podiatric Surgery, a team of specialists that works together to care for patients with vascular and other diseases. Today we are going to discuss about stroke prevention. And with me here is Dr. Rahul Agarwal, who is a consultant vascular and endovascular surgeon. So Dr. Rahul, what are the patients or what are the methods that we are looking at stroke prevention?
Stroke, as we know, can be because of different reasons, like it could be because of a sudden cutoff in the blood supply or even in the bleed in the brain. First and foremost, something called as a risk factor modification, in which a patient who is at a risk of developing a stroke, we should control or treat the risk factor, like controlling their blood pressure, controlling diabetes, controlling the cholesterol. So atherosclerosis, if we know, it's a systemic disease.
And tobacco use.
Absolutely. So atherosclerosis, which is actually the plaque formation, or in common language we say blockages. So the diabetes, hypertension, smoking or any form of tobacco use can aggravate this and cause blockages. So can lead to sudden blockages in the brain causing stroke. So risk factor modification is the first and the foremost at which what we should look at to prevent stroke.
I agree. And taking care of risk factors is important not only in preventing stroke but also in preventing recurrent strokes once you have something and then you have been treated for it. So it's something that you will take lifelong. So ultimately it's what we call a healthy lifestyle, which will prevent a lot of cardiovascular or preventive diseases or the non-communicable diseases. So Dr. Rahul, today let's focus on carotid disease. Now a lot of stroke occurs because there is primary disease inside the brain, and that may account for about 70-75%. Now 20 to 25% of strokes will occur because there is a narrowing in the arteries in the neck.
Yes.
And how do we recognize this narrowing?
As you said, that these vessels, which are called as carotid vessels, now the blockages in these can be recognized by screening is one, because if blockages in the heart is commonly known. Now a patient having a blockage in the heart means he can have blockages anywhere in the body.
Right.
So those patients specifically should be screened by simple ultrasound, get the carotid vessels screened. That is the first and foremost. We can identify these patients early. Secondly, any patient who has got a stroke should also get the carotid screen to note if there is any plaque there or blockages from where the clot must have formed and went to the brain, causing that stroke. I think these two are the most important to identify a person at risk of stroke and already also a cause of stroke.
So commonly when we examine patients with peripheral vascular disease, now we believe that it's a systemic disease affecting all the arteries in the body to some extent. And when we find that, one thing we do is in the clinic itself, we can check with a stethoscope to see if there is any abnormal sound over the vessels, what we call a carotid buoy. We have ultrasounds in our clinic and we do a screening ultrasound for the carotids. And of course, as you said, if patient has stroke, then we would like to do more imaging in the form of either a CT angio or an MR angio, in which we would image the arteries in the neck as well as arteries in the brain to decide about intervention.
Yes.
Now, what is the type of plaque and what is the degree of narrowing in the artery which will make you say, okay, this patient needs a procedure?
To say that, first of all, is the patient had a stroke or not? A patient who had a stroke has got a very high chance of having a stroke again if he has got a blockage in the carotid artery. Now at that point, how much is the narrowing does not matter that much compared to the type or the echogenicity what we can see on ultrasound or the plaque nature. if a plaque is vulnerable, there are certain features which we can note on ultrasound or even on CT that it's a vulnerable plaque. Then they should be offered an intervention for the carotid surgery, for the carotid plaque.
So we typically see, we've actually become quite good at identifying the nature of plaques on ultrasound because we screen so many patients. So plaque, we call it a soft plaque or a vulnerable plaque or a labile plaque from which cholesterol pieces can break off and go to the brain. And these are patients who require intervention at the earliest, because the earlier we operate, the more the chances that there will be no recurrent stroke. And typically we would like to operate within the first 14 days of a stroke or
Yes.
a TIA, what we call a transient ischemic attack,
Yes.
in which there is transient weakness.
Transient weakness, yes.
And then the patient sort of recovers
early, within 24 hours.
Yeah. So it's like a warning sign. So what are the procedures that are available to us to deal with these plaques?
So basically there is something called as endovascular procedures, in which we can remove the clot or actually put a stent there to prevent this plaque from throwing more embolus into the brain. And another gold standard procedure is to actually do an open surgery where we remove the entire plaque so that the risk of having stroke is brought down almost to less than 10%.
Yeah. So what we do is carotid endarterectomy is open surgery, and probably in patients who have had symptoms,
Yes.
either with TIA or stroke, this probably is the gold standard and the best procedure with the lowest risk of stroke during or after the procedure. And it's done under local anesthesia, is reasonably safe. For patients who are not suitable for endarterectomy and have been symptomatic, for example, the plaque is very high in the neck and is surgically not easy to approach
Yes.
without high complication rates. Those are situations where we would say, okay, stenting can be
offered to them.
But if we find a patient who has high-grade stenosis, let's say 80% or 90%, and we think that, okay, this patient may benefit from intervention, those are patients where we could probably look at either procedure.
Yes.
And of course, you will agree with me, there are some situations where we should not offer stenting as a primary procedure, even in asymptomatic patients. If the plaque is labile or vulnerable
Yes.
or soft,
Yes.
even though it has not yet caused symptoms, or a plaque which is very hard and grossly calcified, because that can really rupture the artery when you try to balloon and put the stent
Yes,
inside.
absolutely. So you can relate that soft plaque to a form of a butter.
Yes.
If you're putting a stent through a butter, that clot or the soft plaque is there, it just pierces, or it's a watermelon, the seeding effect, what we can say. Through the mesh, it can come out and
Yeah.
go to the brain.
Yeah.
Person who may not have a stroke, you're creating or giving him a stroke now.
And again, we would like to reiterate that taking care of risk factors after
Yes.
carotid endarterectomy or stenting is vital.
Definitely.
So managing, just to repeat, managing your diabetes, controlling your blood pressure, zero tobacco use, taking care of cholesterol, and nowadays there is a lot of focus on LDL cholesterol, active lifestyle in terms of walking, exercise, and of course a healthy diet.
Absolutely, sir.
Any last minute or any last message, final message you would like to convey to people?
Well, prevention of stroke is very important. If you have noted any blockages anywhere, also get your carotid screened, because if you get a stroke, it's something which will not leave you lifeline. But if you prevent it, you can have a healthy life.
True. And if you get stroke, then be fast and get to the hospital at the earliest for maximum chances of recovery.
Yes.
Thank you.
Thank you.